Kenya ranks third worldwide in teenage pregnancies, according to the Ministry of Health. Now, recent data also released by the ministry shows 1 in 5 adolescents aged between 15 and 19 are already mothers or pregnant with their first child. While such statistics have caused an uproar from both state and non-state actors, who are now calling for immediate action. And the rights organizations and gender activists say it is time we had a robust strategy to tame the menace. Well, joining me in studio to explore solutions to the scourge of teen pregnancy in Kenya is Dr. Nelly Bosire, an OBGYN and founder of Thriving Teens Foundation. But first, let's hear from some young women who bear the burden of becoming mothers too soon. Take a look. Last April was when Belinda's life, not her real name, would change forever. She got pregnant while in high school, cutting short her studies. At 3 months pregnant, she broke the news to her parents.
Akanipiga and then akanipea fare, akaniambia niende kwa mwenye alinipea ball. But sasa mimi kijana mwenye alinipea ball tulipatana na yeye, but ni kijana wa shule pia, alikuwa form 4, alimaliza last year. Alikuwa anasomea shule nyingine na mimi another school, so tulikuwa different schools. So mimi after tumepatana na yeye si kuchukua namba yake ama nini, so like ikakuwa hivyo.
She resorted to living with a cousin in Machakos, who then referred her to the Kyoto Rescue Center in Murang'a.
Nimekaa hapa Kyoto nikiwa sina stress, like we have good mothers wenye wanatu take care, and the organization pina take good care of the girls, so I appreciate them.
Belinda plans to go back to school next year and take up a vocational course in baking or fashion design to support her and her child. About 208 girls and women have been taken in by the center, with 74% of them being teen pregnancies.
We keep young girls or young women who are in crisis pregnancy. We receive them here at the Kyoto and keep them, stay with them for a short time during the time of pregnancy. Then after they deliver, we reintegrate them back to the society. But also the other thing we do here is we facilitate antenatal care and ensure that the girl has delivered safely.
Sheila, not her real name, is currently pregnant and was brought here by her aunt.
Nikaletwa, nikasaidika, nikafurahia kukuja huku, nikasaidiwa na wazazi wa huku, wakatusaidia. Nikijifungua naweza taka kuenda kumaliza shule, nikimaliza shule naweza enda college, naweza taka kuwa nurse.
Kyoto Rescue Center in Murang'a is one of 2 shelters under the Protecting Life Movement Trust that supports young pregnant women in distress. Here, they engage in various activities, from tending to the small garden where they grow vegetables for their consumption. The center also has a project for making beaded jewelry, cards, mats, and detergents. In the afternoons, the house mothers provide the girls with lessons in life skills. Protecting Life Movement Trust founder Dr. Jean Kagia has seen her fair share of teen pregnancies and noticed a particularly worrying trend.
So we went back to our statistic and asked, what is the incidence of incest, girls who are made pregnant by family members? And we found that before the COVID lockdown, it was about 11%. And then we looked at the 1.5 years when we are in a total lockdown, we admitted 30 girls. Out of those 30, 10 were from incest. So we moved from 11 to 30. Out of the 10, 3 of them, another 30%, was from grandparents.
This is exacerbated by the fact that most cases are not reported, hampering efforts to get a real picture of the scale of the problem. Dr. Kagia has been advocating for a multi-sectoral approach in tackling the issue of incest from the school level all the way to the courts, especially since home is where the abuse happens.
What does the legal world do, the judiciary? I was very happy to read that our Chief Justice, Honorable Mother Koome, said that all GBV cases will now be dealt with the courts. But you know, the process is still very long. It gives room for people, one, for children to have nowhere to go. It gives room for dynamics to change. So maybe I'm thinking like a doctor. We have what we call emergencies. So in these GBV cases, can they set up a court for incest? So that when somebody is caught with incest, he goes in quickly, he's prosecuted, removed from the society, and put in. That will do two things. It will help other people realize it's not a good thing. Two, this child who has nowhere else to go will be able to go home. We hope the mother who is protecting her husband will accept the child.
For now, stakeholders like Dr. Kagia attempt to offer support to young women and girls who find themselves victims of abuse and rejection at the hands of those who they call family. All right, still in studio here with Dr. Nelly Bosire. Thank you so much for coming in. You know, as you watch that, we've put some voices, not faces, to the statistics I talked about earlier. It's a big problem in this country.
Absolute big problem.
What's driving the numbers from what you've seen?
Well, I think one of the things we have to appreciate is that Kenya is very diverse.
Yeah.
And sometimes maybe that's one of the problems we don't appreciate, that the drivers of adolescent pregnancy are not uniform throughout the nation. So we have places like Samburu where 1 in every 2 girls is actually pregnant before they're 18. And this is really chiefly driven by the culture of early marriage. So you move to places like West Pokot, it's going to be just as high. They have about a 37% rate of adolescent pregnancies. So these are very culturally driven. For instance, you'll find in a community where the girl from the day she was born, she was already betrothed. So this man has been paying cows over the period of 10, 12, 13 years. He's like, I'm tired of waiting. I've finished paying. I want my property. And so when this girl is getting married at the age of 13, 14, you find that the parents, the father has no appreciation of a girl child, does not see them as their child. They actually see them as a source of cows. So she will be married off, and immediately she's married off. She's expected to get into the business of being a wife, which is including having children. So for them, a lot of the girls that you're going to deal with are actually married, but even worse, they'll be brought to hospital by the so-called husband. So how do you protect her from her abuser? There has to be a lot of cultural, change around that space. We then have what everyone just thinks, that adolescents are just sexually active. When they're just too young, they shouldn't be active. And you can see what Dr. Jean Kagia is giving as an angle that we don't think much about, that a lot of these girls are actually getting pregnant in the space where they're supposed to be safe. Right. Their protectors are the ones who are turning against that oath of protection of their own children, and they're abusing them or causing pregnancy. So by the time you're just looking at the back of these girls who may get pregnant in a space where maybe to some extent are viewed to have had a choice in getting pregnant or not, that population is actually not as big as we think. So why are they getting pregnant? First of all, lack of information. Yeah. We are parents who were raised and not told much about sexuality. So how are we going to teach our children what we weren't taught? And so we have struggled to be having to introduce comprehensive sexuality education in our society. And one of the biggest forces that we have faced against has really been the church, which is saying children are not supposed to be sexually active. We're not supposed to be talking to them about sex. They're not telling us then what are we supposed to do in this place, because they are getting pregnant. And I have worked with young people for a long time. Yeah. it is amazing how much they actually don't know. We are making an assumption. When we talk about exposure, or they're watching too much TV, they're watching too much movies. Yes, they are. They're learning the wrong things. So where are we fitting in the space to actually teach them what is correct? And a lot of the times, people assume that comprehensive sexuality education is having conversations about sex. Actually, it's not. It's an empowerment of the mind for a child who is at an age where her biology and her psychology are not at the same age. We start getting adult to adolescence as early as 8 now. We have children having periods from the age of 8. This 8, 9, 10-year-old is capable of becoming pregnant, but her mindset doesn't know what's wrong, what's right, and when to say no. So if we're going to let her grow up enough to learn to make up the decision, her body is not waiting.
I have to ask this because the adolescent reproductive health space is grossly underserved.
Absolutely.
You know, what are the areas that we are kind of missing when it comes to this demographic? And I mean, you've talked about sexual education, but what more can we do?
There's a whole lot more. First and foremost, when children are young, we have seen the emphasis of trying to ensure that children get to see their 60th month of life. So the focus on the 0 to 5-year-old is very intense. These are children attending clinics, they're getting vaccinated, they're going for well baby checkups. We're monitoring growth, we're trying to weed out malnutrition for an early age. We're doing everything to make sure children see their 5th birthday. And then they grow up, they're a bit more independent, they get to pre-adolescence, they're leaving home, they're going to boarding schools in high school. They're in a space where they're probably at their healthiest. Okay, they hardly ever fall sick. So the transition from the pediatrician to the physician, who is really the equivalent of a pediatrician at the adult stage, has a gap. And this gap is running all the way from about 10 to 20. And when this transition is happening, people always forget the reproductive health side. So if you have a child who has a chronic condition, for instance, let's say they have a congenital heart disease, the pediatric cardiologist is going to walk with them this journey and then hand them over to the physician and a cardiologist. But no one ever remembers that this whole human being side, that reproduction kicked in. So there is no transition, there is no appreciation that this transition exists. So not only don't we prepare them to understand what's healthy and what's not, and not just in the issue of sexuality, but reproductive health in total, that you're a whole human being. This part of your body developing, it actually affects the rest of you. So we fail in appreciating it from the health space, but we also fail then in translating the same to the social space. And so you find that even as family, as parents, the adolescent is the last child to actually report they're sick. This is the child who you will find sleeping, and the mom is going to be like, why are you sleeping today? And they're like, oh, I'm having cramps. Oh, I have a headache. I think I have a fever. If they were a baby, it would be picked really quickly. Everyone's looking out for the baby. But when they're a little bit independent and they are beginning to create some space of their own to develop independence, we're not paying as much attention to them. We start to miss out on things very, very early on. Before we wake up, we are in a really big space that we have failed. So I do appreciate that we do need to tie up that space, and we've kind of just let it go. Let them to their own devices, left them to their teachers who don't know what to do with a class of 60 adolescents who are representing everything, you know, in personality. They're going through transitions, they're trying to find themselves. They don't know who their friends are. They're worried about their self-esteem. They're worried about, you know, how they relate with friends, whether they have friends or not. There's so many challenges they're facing. And the person who's here to give them a formal education is also expected to be their psychologist and counselor and parent. And no, it can't work. So we tend to drop the ball there and not look at this person as wholesomely as we looked at them at 0 to 5 years.
And speaking about that holistic approach, Dr. Nelly, because we're talking about now a teen mother, right? Oftentimes the focus is put on the child for obvious reasons. They've just come into the world to make sure that health-wise they're taken care of. But we're not looking at the long game.
Absolutely.
the socioeconomic status of this young woman, as she moves forward, we're going to be seeing a full generation of kids who are growing up in low-income homes because mom hasn't finished school, can't get a decent job, and can't give you a decent life.
Absolutely.
How do we begin to deal with that before that crisis?
We're basically recreating the poverty cycle and making it even worse.
Yeah.
Okay. We have seen teen mothers from fairly well-to-do backgrounds. And what happens? They are actually able to be reintegrated very quickly in school. In fact, a lot of the times they may actually finish school even without the society being aware that they were teen moms, because there's a whole change of environment. Take them to a new school, take them to a new town, take them to a new country, give them a fresh start. And so it kind of allows them to be children again, you know, and be able to just walk that journey with their peers and fit in somehow. But they're fitting in because their reality is not staring them in the face. Then we have this child who is growing up in a space where the mom was probably a teen mom. This is all she's ever known. So her mother didn't finish school. Her mother had to start looking for menial jobs to stay alive and survive and be able to feed this mouth that she has. And so when this mouth becomes the next teen mom, she's not going to understand it could be different. She's not going to understand what else I can do to make this child go to school. And we also worry about how have we worked on the reintegrating back to school. So yes, it is our government policy that every adolescent mother should go back to school. But it's no longer as easy because you have a child who needs to breastfeed. Is this adolescent going to school supported to be able to continue breastfeeding, take care of the baby at home? Is this adolescent being fed? Remember, she's in a growth spurt. You're feeding yourself to grow at the right pace, but we're also expecting you to feed somebody else. Are we remembering that? So that nutritionally, it's 100% care. Psychologically, she's not ready for this level of responsibility. So that also is completely unsupported. So you're either going to be locked up at home, forgotten from the world, raise the baby, and keep quiet, be grateful you have a place to sleep and food to eat. Or we're actually going to say we're going to be ending up neglecting the new baby who's been born. And that has actually been observed in some communities where I will give an example of, let's say, West Pokot County, where the governor has been very, very committed to education. And as a county, they actually have a county scholarship for putting all children to school. So there is an amount for those who go to day school and those who go to boarding school. And so because of this, parents are able to take a lot of their children back to school, even after they have had babies. But then who's taking care of the newborn? And now from the pediatric side, the team is beginning to get concerned about the newborn's health because they're not breastfed. The mother is looking for school fees for this other child to finish school and come back and take care of the baby she had. And so that, again, it's very hard to keep all these balls in the air. But we must be able to think broadly.
As we wrap up, Dr. Nelly, you know, your foundation, Thriving Teens, what does it seek to do as we are kind of coming up with this collective solution to teen pregnancies?
Exactly that, collective solution. Looking at a teenager as a whole human being and realizing that where we are, when we are talking about how does this child not just survive these years, but begins to thrive in them, means that they have to be made to understand all the facets of their life. That is including the sexual and reproductive health facet. What are your career ambitions? Where are we with education? Who are your mentors? What other medical challenges do you have that can hold you back? And we have a lot of focus on young people with sickle cell disease currently, because these are children that the pediatricians have done a fantastic job to enable them to see adulthood. But we haven't transitioned them in the reproductive health space because they come with very specific challenges. This has also happened to children with HIV. Look at our curriculum. When we teach HIV, what are we teaching our children in school? We only focus on how to avoid getting infected, and once you're infected, how to take your medication so that you don't get sick. Nobody is talking to the children who were born already HIV positive. So when you sit in class and tell them that, you know, if you are sexually irresponsible, you're going to get HIV, this child who's had to live with this condition in school is simply thinking, you're telling me that I am the big bad wolf who's going to make everybody else sick. And statistics have actually shown us that that's the age when they're most likely to rebel, default on their medications, and end up worsening their condition. So the wholesome human being focus. These are not little adults, and they're not big children. They're a very specific category of human beings. They're going through a very interesting transition period that can actually be made fun. Let's not wait for them to fall pregnant. Let's get there, have a conversation, and empower them enough to make the choice to not want to be pregnant now. If we can achieve that, I think we're good.
All right. Thank you so much, Dr. Nelly. We have to leave it there for your insights. But of course, this is a conversation we have to continue if we want to see those numbers coming down.